Welcome to the small bowel skate park. Like any other skate park you've ever been to, the small bowel can be lots of fun, but it's full of potential pitfalls that can ruin your day. Really just poop on your party, so to speak. Let's get started with pathologies that can block up the small bowel, and then move on to some common types of hernias. It's time to drop in. The small bowel is the most common site of intestinal obstruction in the GI tract, due primarily to its relatively small lumen. Just stick to longboarding, kid. The most common cause of GI obstruction is mechanical stricturing of the bowel by adhesions, which are fibrous bands that develop in response to inflammation in the peritoneal cavity, just latching on the side of the bowel, like so. The most common cause of adhesions is prior abdominal surgery, but infections of the peritoneum and inflammatory bowel disease can lead to adhesion formation as well. In addition to adhesions, hernias, intussusception, and small bowel masses or tumors can also cause obstruction. For now, we'll just throw in our recurring cancer crab symbol. Don't worry, we'll cover those other two conditions in just a little bit. Patients with acute small bowel obstruction typically present with nausea and vomiting, obstipation, which is an inability to pass flatus or stool, and some on and off colicky abdominal pain. To show this, we'll sketch in our colicky collie who's ready to shred, plus our constipation plunger, and some nausea and vomiting, which kind of speaks for itself. SBO leads to a backup of gas in the bowels, so on physical exam, expect to find a distended tympanitic abdomen, kind of like a distended drum. Yup, he brought the bongo. He's that cool. Classically, you'll also be able to hear some high-pitched, tinkling bowel sounds on auscultation of the abdomen, which represent the small intestine's futile attempt to peristalse against an acute blockage. Tinkle, tinkle. Small bowel obstruction also has a characteristic appearance on abdominal X-ray. Bowel distension, seen as dilated loops of bowel, along with air fluid levels within those dilated loops. For the classic appearance of air fluid levels, take a look at the graffiti on the side of the half pipe. Gas is less dense than fluid, of course, so these trapped pockets of gas appear darker on the radiograph. Kinda like these dark rain clouds. Also, look for that stark horizontal contrast line that separates the gas from the liquid below. Another sign to look out for on the radiograph is called the transition point, which marks where the dilated proximal bowel transitions to the normal gasless bowel distal to the obstruction. Treatment for an SBO centers on diagnosing the underlying cause and reversing it. In the most common cases of acute SBO, this may mean surgical lysis of adhesions or hernia repair. In the meantime, bowel rest, defined as allowing nothing by mouth and hydration with IV fluids, is the way to go. If the underlying cause of the acute SBO is fixed, the prognosis is excellent. Often, however, the cause cannot be completely reversed, such as in the case of advanced stage cancer or severe inflammatory bowel disease. In these instances, any treatment is merely palliative, and SBO is likely to recur. Let's move on to ileus, SBO's little cousin. Ileus presents very similarly to small bowel obstruction, but it's caused by hypomotility rather than a mechanical obstruction. Hence the more apt term, paralytic or adynamic ileus. So instead of rocks getting in his way, he's having motility issues. Patients with ileus will have the same abdominal pain, obstipation, nausea, and vomiting characteristic of mechanical bowel obstruction, but will not have a transition point visible on abdominal X-ray. Instead, the bowel tends to be uniformly dilated with air throughout the entire intestine. And I mean everywhere. Even the colon and rectum. Just big dilated loops throughout the abdomen. On physical exam, the abdomen will also be distended and tympanitic. However, don't expect to hear much on auscultation. Bowel hypomobility and lack of peristalsis mean that you'll hear diminished bowel sounds, or no sounds at all. Common causes of ileus include recent surgery, drug side effects, diabetes, and severe illness, such as sepsis, or pretty much anything to make you sick enough to go to the ICU. Diabetes causes ileus because of injury to the parasympathetic nervous system, and is one of the classic etiologies that pops up on the test. So we've emphasized it here, with some spillage from the glycemic candy jar. Like SBO, treatment of ileus focuses on resolution of the underlying cause. Until that happens, patients are placed on bowel rest to prevent worsening of their symptoms. All right, on to SMA syndrome, a rare cause of small bowel obstruction. But since it's frequently tested, we'll briefly discuss it here. It's caused by compression of the third portion of the duodenum between the aorta and the superior mesenteric artery, or SMA. This is depicted over at the ramp. Pretend that the kid caught in the middle there is the duodenum. That makes the ramp underneath the descending aorta, and that arterial rail the SMA clamping down on the trapped intestines. SMA syndrome is most frequently associated with severe or very rapid weight loss, typically as a result of severe illness or prolonged hospitalization. See those pads strewn on the ground? When weight loss occurs, the mesenteric fat pad can shrink to such an extent that it no longer pads the space between the superior mesenteric artery and the aorta, which is where the duodenum calls home. Without that soft, fatty cushion, the two vessels can clamp off the third portion of the duodenum, resulting in obstruction. Patients typically present with recurrent, unexplainable abdominal pain after eating, hence the painful burrito. Nausea, vomiting, and obstipation are also likely in more advanced cases of obstruction. SMA syndrome is a rare diagnosis of exclusion, so don't go about making it the tippy top of your differential until you've ruled out all the other, much more likely causes of SBO. Like intussusception, for example. Well, actually, this one's also pretty rare. Intussusception occurs when a segment of proximal small bowel is pulled distally into the bowel ahead of it, creating a telescoping effect. Kind of like this telescoping camera lens. It's most common in young children, generally between 2 and 5 years of age, and is a surgical emergency when it happens. That's because intussusception leads to impaired venous return from the telescoped segment of bowel, which can cause ischemia and subsequent necrosis of the intestinal wall. Now, a normal gut doesn't have any weak spots for the bowel to telescope in on itself. What's required is a lead point, some discontinuity within the bowel that will allow the intestines to fold inward, creating an intussusception. In toddlers, hyperplastic lymphoid tissue in the small bowel that grows following a viral infection serves as the lead point that is pulled into the distal bowel. Weird, right? And it's sketchy. Lots of lymphoid tissue means a big pile of tissues, of course. Pfft, get up, kid. Whiner. What, are you allergic to winning? In older children and adults, a more permanent lead point, such as a Meckel diverticulum, polyp, or tumor, should be sought. So not only have we brought back out Meckel's hecklers from the congenital GI sketch, but we've also decked them out in some oddly polyploid headgear. What? Still with the twos? Oh, come on. That was a picture-perfect quint whip flat. The most common location in the bowel for intussusception to occur is at the ileocolic junction. Notice that we've depicted this junction right where the smaller ramp meets the landing zone. Why here? Well, the size differences in the adjacent segments of the intestine at this point allow the ileum to telescope right into the cecum. Patients with intussusception typically present with symptoms very similar to that of small bowel obstruction. Severe colicky, intermittent abdominal pain, nausea, and vomiting. Which makes sense. The bowel is obstructed, just with itself. In addition to those findings, patients may also have classic current jelly stools that contain blood and mucus. Why scientists use food terms to describe poop, I'll never understand. A tubular mass may be palpable in the right lower quadrant, just like a handlebar to the midsection. What you're feeling are the swollen, intussuscepted portions of the bowel. It's most commonly palpated in the right lower quadrant because that's where the ileocolic junction is, the most common location for intussusception. On abdominal ultrasound, the telescoped bowel may create a target sign of bullseye appearance, which is the two segments of bowel telescoped into each other, seen on cross-section. Interestingly, a barium enema can both diagnose and fix an intussusception. The physical act of shooting contrast backwards through the intestines can actually push the telescoped portion of the bowel back into its normal place. Aw, man, this guy's sponsored already? If the intussusception does not resolve with barium enema, however, the only way to reverse the intussusception is through surgery. Enough about obstructions. It's time to move on to hernias and talk about all the different ways the bowel can poke through the abdominal wall and get stuck. To be fair, we won't be covering every type of hernia in this sketch, but that's because the word hernia is very generic and simply refers to a protrusion, bulge, or projection of an organ through the body wall that normally contains it. In fact, there are over 10 different types of abdominal hernias, but we'll just be covering groin hernias, which are by far the most common and what people colloquially refer to when they say hernia. Groin hernias are an incredibly common condition, accounting for numerous elective and emergency surgeries each year. Hernias occur due to a weakening or disruption of the fibromuscular tissues of the body wall, allowing intra-abdominal contents to protrude through the defect. See that weakness in the fence there? It's the perfect place for a few trespassing teenagers to sneak through. These abdominal wall defects can be congenital or acquired. And by acquired, I mean that these defects can develop after surgery, or from chronic elevations in intra-abdominal pressure. Think of things like heavy lifting, cough, constipation, strenuous exercise, or pregnancy. Over time, enough damage has been done to the abdominal wall that, plop, out pops some intestine. I mean, just look at the guy. All that pressure. So puffy with rage. We'll discuss the specifics of congenital and acquired hernias while illustrating the 3 types of groin hernias in a moment. But first, let's cover some general features common to all groin hernias. So what increases your risk of developing a hernia? Well, for starters, hernias are more common in men compared with women, and in Caucasians compared with non-Caucasians. This is most likely due to the much more developed processus vaginalis and the presence of the spermatic cord in men, which both increases the risk for persistent processus vaginalis up to 50% of men, and increases the size of the internal inguinal ring compared to females. In addition, hernias are more likely to occur in older individuals compared with younger people. That's because the strength of soft tissue lining the abdominal wall decreases with age, making it more likely for defects to occur and hernias to poke through. When a hernia develops, omentum or small bowel are more likely to herniate through the wall defect, but a large enough hernia can trap all the parts of the bowel inside, including the colon. The danger with hernias is akin to getting your head stuck between the rungs of a ladder. It may be easy to squeeze in, but it's much tougher to get back out. When hernias become stuck, this is called incarcerated, kind of like handcuffs preventing movement, and more than likely cause you to become incarcerated, if you know what I mean. Yeah, I've been on the inside, so what? Incarceration is the initial step that sets off a chain reaction of badness. See how the chain now looks like constricted veins? When a hernia is unable to be reduced back into the abdominal cavity, swelling develops as venous and lymphatic drainage become impaired. Eventually, the swelling can compromise blood flow to the entrapped bowel, leading to ischemia and necrosis of the hernia. This part is called strangulation. Yep, it's just like a noose. The damage done can quickly become irreversible, leading to bowel necrosis, perforation, and even sepsis. That's why incarcerated and strangulated hernias are surgical emergencies. All right, to fully understand the different types of hernias, you first have to visualize the different regions of the anterior abdominal wall. Don't groan. You're guaranteed to get pimped on this at some point during your surgery rotation, in addition to being asked about it on test day. Groin hernias can be divided into inguinal and femoral. Since femoral hernias are much more rare, let's focus on inguinal hernias first. Inguinal hernias are categorized based on the path the hernia takes in relation to Hesselbach's triangle. The borders of Hesselbach's triangle are illustrated here. The inguinal ligament makes up the inferior portion. Since the inguinal ligament forms the base of the inguinal canal, we've drawn a ligamentous tarp underneath this inguinal skater tunnel. The inguinal canal is the usual passageway for gonadal vessels in men and the round ligament in women. Forming the medial border is the rectus abdominis. Yep, a big band of striated muscle, as depicted by that striated wooden frame. And lastly, the lateral border is formed by the inferior epigastric vessels. There's an artery and vein there, coursing upwards behind the rectus. Direct hernias pass directly through the Hesselbach's triangle, medial to those inferior epigastric vessels, in other words. Indirect hernias, on the other hand, pass laterally through the inguinal ring and into the inguinal canal. Femoral hernias pass posteriorly right under the inguinal ligament and on through the femoral canal, which is normally filled with femoral vessels. Because indirect hernias pass through the inguinal canal, they're covered by all 3 layers of the spermatic fascia, specifically the external oblique aponeurosis, cremasteric fascia, and transversalis fascia. So we've drawn him bundled up in a hoodie. Cozy. Direct hernias pass through the external inguinal ring, but not through the internal inguinal ring. Because of this, the hernia contents are only covered by the external spermatic fascia. Just an external shirt on this kid. Not a good look. Direct inguinal hernias occur as a result of weakness in the posterior wall of the inguinal canal, which just means that right behind the canal, the abdominal wall is getting weakened. Just like this fence here. chronic overstretching leads to injury. Most indirect inguinal hernias are actually caused by a congenital defect involving persistence of the processus vaginalis combined with the other risk factors mentioned above, like increased intra-abdominal pressure. So, since there is a patent processus vaginalis, we've labeled the canal Virginia Co, along with a patent number underneath. Interestingly, indirect inguinal hernias can lead to bowel accumulation in the scrotal sac of men. Since the inguinal canal leads directly into the scrotum, femoral hernias are like the neglected little sister of groin hernias, since they occur much less frequently than the inguinal hernias. They also tend to occur more frequently in women, likely because pregnancy can affect the pelvic anatomy and widen the femoral ring that pokes through to form a femoral hernia. Even though femoral hernias are the least common type of groin hernia, they have the highest rate of incarceration and strangulation due to the small opening of the femoral ring. And there you have it. Everything that could possibly go wrong with the small intestines. Well, except for cancer and vascular stuff. So to continue with our small bowel adventure, we're headed into the sewers. Cowabunga! Not my best landing. Okay, that doesn't look good. Oh, and there's sewer water all over it.